All right, folks, thank you so much. We are going to continue our session. Our next series of presentations will be addressing HIV and substance misuse in Appalachia. This conversation will be facilitated by Greg Alton and Vincent Guillamos-Ramos. Gentlemen.
Well, thank you, John. So as John said, we're going to be kind of digging in deeper to HIV and the role of substance misuse in Appalachia for this panel. The last panel we went through the epidemiology. We said it was a really great platform to start with. I want to start by thanking Tony as well, Tony Young as well, for getting us here. And also, I've known Tony for years, and she's been trying to get me to West Virginia for a long time. And I thought maybe if I came this time, then she'd leave me alone. But no, now she's like, she's really trying to get me to do more and more. I also want to reflect on yesterday. We spent the day visiting, and I can see some faces out here that look familiar to me. Many of the people doing work in the community here in Charleston. And I think we all came away just really kind of blown away by several things. First of all, hope. I mean, you guys, like really, when I see the work that's being done here, we can see things can be done, things are being done. We saw so much energy, so much passion, so much dedication and quality and talent in terms of what you guys are all doing. So that was really great to see. And I think what we're hoping through this panel and today is that we can come away with more that we can be doing from a federal level to help you. I say we, this is my last PACHA meeting, but I'll pass it off to my other colleagues. So we're going to start with the panel here. We're going to do this a little bit different than the last panel. Vincent and I have a number of questions that we're going to do, and we've put these into two buckets, where I'm going to start off asking some questions, really to sort of talk about what's happening now and sort of the situation that you see. And then Vincent's going to turn it towards some similar to other questions, but really towards sort of what can we do moving forward? How can we help? How can we do more as PACHA, as HHS and the federal government? So I'm not going to introduce each of you. We're going to do, we're going to start by asking you to introduce yourselves, talk about what you see as the current situation. We talked about the epidemiology, but what you're really seeing and the work that you're doing within your organizations to address the substance misuse disorder and infection, both HIV and co-infection as well. So why don't we just start down the line and we'll pick it up from there.
Sounds good. Thank you. My name is James Berry, and I am an addiction psychiatrist. I moved to West Virginia in 2002 to begin my psychiatry residency at West Virginia University in Morgantown. Little did I know at the time that we were on the cusp of the nation's worst, what I refer to as addiction epidemic that we've ever seen before. And so when I first moved there and did my training, many of the people that were coming in initially were coming in for typical alcohol problems and maybe some cocaine, maybe a little bit of heroin. But pretty soon in my tenure, we started seeing folks coming in with pain pill problems. And then that trickle became a tsunami that we're all too familiar with now, and find ourselves in a conundrum that none of us could have imagined or hoped for at the time. And so much of my time over the last 2 years has been focused on treating patients and really trying to create access to get people into treatment who desperately need treatment, and then also try to educate my colleagues, medical students, residents, social work students, nursing students on the importance of caring for these folks who are suffering from substance use disorders. And so that's what we've been doing. And then also some research, some groundbreaking research through our Rockefeller Neuroscience Institute in looking at neuromodulation strategies to try to address and treat addiction as well.
Good morning, everybody. I'm Judith Feinberg. I'm an infectious disease doc by training, and was an HIV researcher, clinician, and educator since the beginning of the epidemic, for a very long time. Was recruited here to WVU 8 years ago to develop a program at the intersection of infectious diseases, primarily viral hepatitis and HIV, and endocarditis, and its intersection with the injection drug epidemic, which is a which are all extremely prominent problems here in West Virginia. My current work is really focused on, let me back up and say we have very few specialists in this state. We have 3 hepatologists to take care of all the viral hepatitis. We probably don't have 24 infectious disease docs in the state. And my recent work is really focused on getting people in primary care and addiction care to take on the diagnosis and management and ongoing treatment of these really important infections that are really devastating this community. And not only take them on, but also to integrate the diagnosis and care of people with HIV and hepatitis C and hepatitis B with care for substance use disorder, because there aren't enough addiction psychiatrists. There are 3 in the state, 4.
We have more than that now, thankfully. But
Well,
I think growing.
It's still a handful given the size of our epidemic.
Yes.
So I think that in a state that is so rural and where our substance use and infectious disease epidemics are so dispersed, if we do not bring the primary care community and the addiction care community into the diagnosis and control of these diseases, we're just never going to get ahead of it. So that's been my current focus. I would also share with you that not only is our situation complicated by a limited number of specialists, but really in some studies, the majority of people with HIV, this came from the CDC's EpiAid investigation in the Charleston Kanawha outbreak, 61% had been homeless or unstably housed. In a fentanyl test strip study I've been doing out of the Syringe Services Program in Morgantown, 62% of the people are homeless. So, on top of rurality, lack of transportation, extremely limited access to specialists, we're really dealing with an extremely unstable population in terms of just location. And that is something that that's something that we really need to think about if we're going to get ahead of any of these problems.
I'm Bishop Robert Haley, Dr. Haley. I'm the pastor of a Morrisonway licensed church, also the CEO of Bright Futures Now. And the hard people to reach that you've been talking about are my people. Our church is located on 5 corners. And over the years, we've dealt with, along with Health Right and CEG, we have reached out to the community. We're the boots on the ground. We're the ones that goes out and surveys and talks and reach and feed those people that cannot be reached. We've been blessed to been able to start a health fair 3 years ago due to the fact that our community was not being reached. This is our 3rd year, very successful this year, but we're looking to do even greater. But our biggest dilemma is not being able to get the message back up the stream to those that are in power and those that have the money, that there are things we can do. I'm a Marine, so I believe I can do anything. And they beat that in my head in 74. So that's the way I feel. But the main thing is that we are actually reaching the community. We're actually talking to the people, and we've had great success over the 5 years that we've been at our location. So.
Good morning. I'm Sally Hodder. I'm an infectious disease physician. My current position is director of the Clinical and Translational Science Institute of West Virginia, and I took a circuitous route to get there. I was an intern in 1980 in San Francisco at the dawn of the AIDS epidemic, and then I worked in Kenya, actually on schistosomiasis in the mid-'80s at the emergence of HIV in Africa. And immediately before coming to West Virginia, I ran the HIV program in Newark, New Jersey. We had the highest proportion of HIV-infected folks who were women. Why? Because the HIV epidemic there really originated in the people who inject drugs. I grew up in Appalachia, in a river town,
I got offered this job to sort of come back. HIV was not, this was 2014, on the map at all. And I thought, finally, I'll grow up and do something else besides HIV and do all, science and so forth. And I got here and very quickly realized, as Jim said, that we were on the precipice, huge addiction issues, and clearly infectious diseases were going to be a problem. I recruited Judith 2 years after getting here, and we had been colleagues for many, many years. I would say two things that we're currently doing, three things actually. The Institute has a 131-member practice-based research network. Most are FQHCs. These are throughout West Virginia, and they are some of the most dedicated men and women you will ever meet, and are doing a fantastic job, but they need resources. These clinics are on a really tight margin. And so you want to do research, you want to do something. I mean, that's sort of one thing. The second thing is we didn't create it. We used the ECHO model from New Mexico to amplify community specialty expertise, as Judith was saying, and it's really been a terrific, I think, boon, particularly to hepatitis C, but we have addiction. Jim works with us. And the third thing, given my history in Newark with women, and women, particularly women who inject drugs or who don't inject drugs, are often at particular risk when you have an HIV epidemic centered among people who inject drugs. Number one, they're often last on the needle. And number two, the sexual transmission, is sometimes unrealized. They don't realize their partner may be HIV infected. So we did two things. We did a survey in parking lots of Walmart, Kroger in 2 counties. One was having an HIV epidemic in Southwest West Virginia, and the other wasn't. Interestingly, the one that had the HIV epidemic thought that their number one problem was opioid addiction. The other county thought it was obesity. Not that that isn't a problem, but that was number one. If you look then, do you think infectious diseases are important? And we did this just as COVID was starting. So, only about 25% said it, related infectious disease were a problem. The county that had the outbreak, the ongoing outbreak of HIV, actually 5% of the people thought that syringe services should be a priority. And in the county that didn't, it was under 2%. We then did interviews of 88 women, most of whom were used substances, many of whom were people who injected drugs. And back to Dr. Kilkenny's excellent point, among those women, 86% said, I am not at risk for HIV, or rarely do I ever think about it. So we've got a lot of work to do.
Good morning, everyone. My name is James Patterson. I'm a reverend by calling, and I'm also the CEO of the Partnership of African American Churches. We're a nonprofit organization that's been around for 21 years or so. And our mission is to improve the health outcomes of all West Virginians while intentionally including communities of color. Because of the population of the state of West Virginia, if you're going to do anything as it relates to people of color, you have to be intentional in doing that. And we also like to use the definition of health from the World Health Organization that says health is not simply the absence of disease, but the entire well-being of the individual. So we are comprehensive in terms of what we try to do. We do everything from after-school programming, which we start doing 21 years ago, to actually now we are a certified healthcare provider. So that's what got us into working with people that have substance use disorder. We have 76 treatment beds. We go from level 2 to level 3.5, and of those, there are 52 for men and 24 for women. And so we are actively trying to deal with this substance use disorder challenge that we have here in the state of West Virginia, all the way from prevention, after-school programs, until treatment on the top end. I'm done.
Good morning, everyone. It's an honor to be with you today and to sit with such a panel of esteemed colleagues from across the state. I'm Lynn O'Connell, and I'm the Associate Director for Addiction Sciences at the Jones C. Edwards School of Medicine at Marshall, and I sit within the Department of Family Medicine. And as Dr. Feinberg acknowledged, we don't have a lot of specialists, and so it was time for primary care to enter the conversation and take ownership for the idea that it is a primary care disease and can be treated as such. And so the Department of Family Medicine developed the division 5 years ago. And at the time we were 2 people. We're now just north of 82 individuals within the division across mostly the southern portion of the state. Our primary goal was direct access and low barrier access to treatment. And that means that we developed what's called PROACT. You can walk in right now and receive an immediate intake involving an individual intake, group and family services, pharmacological services on site, spiritual care services on site, nursing, infectious disease treatment, and testing on site. And it's all pathways to recovery, so an individual can choose medication or other forms. And then we are also integrating psychological services and employment and educational referrals and networking. We operate a program through PROACT and through 3 other hubs in our 16-county region called CORE, creating opportunities for recovery employment, because the opposite of addiction is not just recovery, it's connection and reintegration into the community. And as Reverend mentioned, that view of wellness as a whole health need and not just for that individual. I'm a licensed marriage and family therapist by degree, and I moved to West Virginia in 2014, where I provided direct service for my first year, and then I ran an SBIRT grant, screening, brief intervention, and referral to treatment, and had the honor to then integrate stigma into that curriculum for SAMHSA, and then integrate not only substance use treatment and referrals, but infectious disease treatment and referrals to normalize that conversation, especially with our peers on the streets and in our unsheltered programs and in our hospitals. And so out of that, eventually I ended up at the med school. So as I said, our primary goal is low barrier access. Our second goal is ensuring that women have the opportunity to be reunified with their children in comprehensive care. And so we operate Project Hope for Women and Children, which is one of the highest levels of care in West Virginia. At the time that we developed it, it was the only program that allowed all pathways to recovery and a mom to bring up to 4 children into care and to be pregnant and parenting at that time. And so we really work on that full family system, receiving treatment and testing and normalizing those conversations. And so we integrate our medical students and our residents into conversations around testing for substance use, testing for infectious disease, and testing for any other medical condition. We have moms who don't just want any blood work done, not because of infectious disease, but because of any engagement sort of with the medical system. And so we work to normalize that. Our other initiatives have been, part of my role is to sit with the Mayor's Council for Substance Use and Public Health for the city. And our goal there is to develop a pathway that helps navigate individuals through substance use treatment programs, whether that be that they are ready or willing to engage in harm reduction. Maybe they're not there yet, and that they just need supportive services on the streets. If they are willing to move, many times I always visualize the idea that we're holding on to folks, and the minute that there's the tiniest gap is when people fall out of care. And so we're developing pathways so that people always have someone paired with them, and trying to use integrated technology in electronic health records and other HIPAA compliant 42 CFR Part 2 compliant consents to share that information. And our goal is to expand that in the future to infectious disease. So if an individual falls out of care but has received the first round of treatment or is on PrEP but needs that second dose and they pop up in Charleston, that we would be able to flag that provider. And so those are our hopes in working with that. And lastly, we integrate with the Governor's Council, and I'm the chair of public education, which is predominantly the stigma campaign as part of what Dr. Christensen was talking about earlier when his role was with the Office of Drug Control Policy, and many on this are also sitting members of that panel. So thank you for having me today.
Well, thank you very much. So we're going to go into some other questions, and a little bit different. So that was sort of the round robin, getting everyone to answer a question. We're clearly not going to have each of you answer each question. So I'm going to ask questions. Vincent will ask some questions, and volunteer to answer where you feel you can add. So I want to talk a little about, you mentioned stigma a little bit, and this came up in other conversations. And what we're obviously dealing with here is two levels of stigma. Number one, against people who inject drugs, but also, as mentioned in the last panel, because we're talking about HIV, people are reluctant to, for example, be on PrEP because it's perceived as a gay drug or a gay disease. And so want to understand from your perspective the role that stigma plays in the challenges that you see, whether it be for getting people screened, whether you get people in treatment, or just to come into care, people's perception of risk as well, and what you're doing about that, what kind of programs you have in place or approaches you have to address stigma. And I'll open it for whoever wants to volunteer. If not, I can call on people too, I think, right?
I'll take a first stab at it from the top level approach. And I know there's a lot of on the ground approaches that we can all address. As part of the Office of Drug Control Policy, so I'll put on that hat for a moment, the Governor's Council has sought to develop a comprehensive stigma approach that's addressing both everything systemically. So we've done surveys about what are the most targeted or what are the most populations that need unique interventions. So for example, pregnant parenting women, they face a higher level of stigma around substance use, around infection, around testing, and just around sort of their entire even single parenthood status. And so when we look at all of those different populations that need approaches, the goal as we move forward is to do a top-down and a bottom-up intervention. I'm not a marketing expert by any means, but in working with our marketing partners, one of the things that we've identified, and I'll give you my dumbed-down version, which is every year when, everybody knows what Coca-Cola is, and they release new types of Coca-Cola like Coke Cherry and Coke Lime and Diet Coke, but they don't rebrand the entire company every time they do that. They stay with Coca-Cola, and then they might have a unique campaign that's around what their new product is for a brief period of time. What we've seen in stigma campaigns is that they change yearly, is that there's a new focus, a new approach. This year, we're going to target those on MAT treatment. This year, we're going to target family members. And every time the campaign changes, there's no lingering brand. So the brand is Coca-Cola. The campaign is Diet Coke or Coke Lime. And so what we're trying to do is develop a stigma campaign with that same lens, is that there needs to be a long-term brand with sub-campaigns addressing different populations in unique ways that meet that population. And so that might mean that it's completely driven by, engage, educate, protest, connect. Those are the three things you need to do to address stigma. So we need to educate individuals so that they have the skills to protest, which means to combat negative information without reinforcing the myth. So you don't say, you might have heard that PrEP is a gay drug. It's not, and then combat it. Every time you reinforce the myth, you unfortunately reinforce that stigma. And so then finding a way to then connect them to someone with that lived experience. And so with each of our subpopulations, whether that be law enforcement or PPW populations or those who are unhoused, ensuring that the person delivering the message from the bottom up is fully versed in the campaign, but is also buying into the brand overall. And so this is something we're trying to do right now in a strategic way, is to develop that long-term 3 to 5 to 10-year strategy to start addressing stigma so that all of these things are not separate. Because when we get into the battle of resources, we don't have enough resources to be fighting over that. There needs to be capacity building, not duplication or competition. And so when we look at a stigma campaign, how can we all be working towards the goal of the brand, whether that be you're here for infectious disease or people of color or pregnant parenting women, but rather we're disseminating those resources from the brand to the campaigns so that they can support it.
I would say one of the main things that I look at as relate to stigma is how people are treated when they are in your facility, as well as what is the reputation of your facility or your treatment or your organization that's in the community of the people that we're trying to serve. And so as CEO, it's my job to make sure that from top to bottom of the organization, that people are treated with care and compassion and no matter what their condition are when they come to see us. I have a story. This is true. I went to a physician and one of the doctor in the boxes. And for those of you all that are medical professionals, excuse me for saying that, but you know, one of those two places you go when you can't get to see your physician or whatever. And this was about 2 weeks ago. So when I went in, they asked me, they said, do you want to see a nurse practitioner or a physician? I said, nurse practitioner is fine. So I go in the room and and they take all this stuff. And so the nurse practitioner comes in and he has my chart. And he looks at me and he says, well, bub, I said, hold it. And I'm telling the truth, you know, I'm a preacher, but I almost cussed. I really did. Think where we are. You know, this is 2023, and this is supposed to be a medical professional, and he's calling me Bub, and has my name on the chart. So I thought about that in terms of how do we treat people that are dealing with an illness as well as addiction. And so I think that's the way that we deal with stigma, is that we make sure that we're on top of what we're supposed to do and how we treat people in our facilities.
Part of our work with FQHCs and other primary care settings is to do exactly what the Reverend just described, which is to ensure that that not only the provider, who might already be well disposed to thinking of these problems as diseases and being prepared to treat them, but to ensure that the intake person, that the receptionist, that everybody that faces the public, you know, does so appropriately. Because, you know, you can be turned off at the entrance. And you know, and then you'll never get the care you need.
Two things that we have done are we've been involved with. We have our health fair, which is totally awesome. But we have West Virginia School of Osteopathic Medicine brought their first, second, and third year physicians down to work with us. They got out with the people. They talked to them. And like a year ago, it was totally different. This was our first time. They were somewhat scared. But this time they got out and they talked with the people. And actually people in our community asked me, well, when are they coming back? It's different because you went out from behind the table and you were over eating Slurpees with them and chips with them and things like that. It's very important. We have at our church every day, twice a day, we have 40 recovery ladies that come to our church. They come there, they do their training and stuff, and they leave. Not one of them women will ever tell you that they were treated any different than if a parishioner or any other person came to that church. And a lot of times, especially with people of color, there is a barrier between them and the medical physicians. There's a lot of mistrust. There's a lot of, you think back that Grandma Jones died in the hospital under this doctor, didn't realize Grandma Jones had about 40 different diseases, and she was on her way out of here anyway. But the fact is that is not just 40 years ago, it's right now. Part of our program is try to get with Reverend Patterson. We're trying to get men to go to doctors. And I thought it was just black men that were afraid to come to doctors. All men, except doctors, don't want to go to doctors. So it's a battle, but that's all really behind things that's going on in their heads.
As a doctor, I'll say we are the worst, actually, about going to see. But I totally love what you are doing there. And I'll say that, at least from an addiction stigma standpoint, over the last 20 years, there has been significant change. We have a long way to go, but there has been significant change between 20 years and now. But sadly, I think part of that is because now everybody has somebody close to them who has overdosed or is suffering from addiction in Appalachia. It's hard to not be affected from this personally. And, you know, when I first started my career, I thought it was educate, educate, educate. That's what we needed to do. But I realized that education only goes so far. And it's getting people in contact with other people who are experiencing these things that makes the difference, because we're human beings, and having that connection and being able to actually put a name, face, and a personal emotional contact with someone else goes much further. So to that effect, right, trying to get people in the healthcare, for instance, into rotations, if you're a medical student, nursing student, seeing what addiction treatment is, seeing what HIV/AIDS treatment is, and that really goes a long way.
Okay. So next, I want to change gears a little bit here. We talked a little bit in the last panel about needle exchange. And some of the challenges, and we heard yesterday firsthand about some of the challenges. That's actually not my question. My question has had more broadly to do with law enforcement, and I'd like to understand a little better your relationship with law enforcement and some of the challenges and some of the maybe if there's any victories that you've had in dealing with law enforcement in terms of, you know, criminalization of drug use, possession of needles, those types of issues.
Well, so far with our church and our group, we have a good rapport with the police officers there. We still have problems with needles around the church, around the community. We have one gentleman that's very zealous. He goes up and picks up needles because we do have children around and things like that. And what we've been able to do is just call a police officer instead of us picking it up, because it's very dangerous for you to pick it up because you don't know what's on the surface of the needle. The police officer will come out, bring the proper tools to be able to remove that, you know, from us. And they don't do it with any hassle. So far, we've had no judgment as far as we're concerned, but they do it readily anytime we call.
We don't have a lot of interaction with police officers. We have had some police officers from time to time have a warrant for someone that's in our facility, and they would come and very respectfully ask for the person, what have you. But our main interaction with the criminal justice system is with people who are coming from incarceration and coming into our treatment facility. And that's a fairly smooth transition. However, they are sticklers for whatever their process is or however it happens. And there are some people who have been in our facility and they did not take care of all of their responsibilities toward the criminal justice system before they entered. And as soon as they graduated, they were arrested and taken back to jail, which I think. But anyway, so we have a pretty good relationship.
I'll share sort of a win. In Huntington, they applied for one of the Bloomberg philanthropy grants as part of the Mayor's Challenge nationally, and that was to develop at the time a program to intervene with first responders, specifically HPD, Huntington Police, and Huntington Fire. And that was developed, and eventually we made it through the pilot stage. Working with that sort of project is very unique. It's not like a SAMHSA where, you know, you submit your grant. If you're not meeting your milestones, you lose your grant. Bloomberg actually wants a trial and fail approach. So you consistently have to pivot in your first year. And they provide you with a technical assistance program called Delivery Associates that actually helped the British Prime Minister at one point develop cabinet positions. It helped Justin Trudeau work on indigenous water resources. So they work on a lot of big projects, but they also came and helped with this Mayor's Challenge. We ended up winning along with 4 other cities and received $1 million to implement over 3 years. And what that became is called Compass Navigating Wellness. During our first pilot stage, as ambitious as Dr. Berry is as well, we went in and said, we'll educate folks. And so That's how I got involved. They knew at the time that I loved to talk about stigma, and that we had done a lot of healthcare trainings on something called Words Matter. And so I went into the fire academy, and to say it crashed and burned would be an understatement. And with that many firefighters in the room, you really thought someone could have saved it. But it was not received well. And in fact, I was immediately informed of how difficult and challenging their lives and jobs were. And I was asking them to hold compassion for someone else. And so I put a stop and went to the advisory team and eventually got placed on it and have had the honor of serving as their mental health provider as part of that team to help us pivot once again. And so we recognize the idea that compassion fatigue is not a word people want to hear because it puts the blame and onus on the individual when they also have been hurt and experienced trauma. And that they were going to the houses of their high school friends and seeing them die. And they were seeing the children of their high school friends watch someone die by suicide or other negative impacts. And so we took a big, hard step back, and we call it navigating wellness. We embedded a mental health liaison and a physical fitness coach liaison in both departments. And we've conducted surveys biannually on everything: PHQ-9, depression, anxiety, resiliency, workforce stress, burnout. There's 13 validated scales to track their sort of wellness throughout this program. And we do focus groups also biannually to hear what things they need. And so they recognized that they needed a critical incident policy that hadn't previously existed. And so we worked with them on that. And so when they feel as though they're getting a win, they were much more responsive. And so they came to me and asked for fentanyl test strips and asked for education about how those were no longer paraphernalia. So we set that up. They then said, we do want to know more about the impact of drugs on the street and the change of, for example, methamphetamine psychosis. So Dr. Christensen was asked to come in and do that. And so we meet them where they're at and try and implement interventions. And that eventually led to the request for a crisis intervention team, which we've just launched. So now law enforcement are with a mental health provider responding to those who are unhoused or those with serious mental illness crises, rather than it being criminalization of that concern.
Yeah, I guess the only thing I would add is just like my experience in noticing a change regarding stigma over the last 20 years, I have noticed a change too with law enforcement and judicial system, in the sense a greater recognition that we cannot arrest our way out of this problem, and we cannot just focus on the supply side of addiction problems, but we really need to try to put resources and address the demand side. Because if you cut off fentanyl, for instance, we've already seen this, right? We saw the change from pain pills to heroin to fentanyl and now methamphetamine. The drug is going to change. And so if we put all of our money into trying to address one drug, folks, it's going to not be successful. And so we got to really address what is the cause of addiction and how do we help give people meaning, connection, and hope.
Well, great. Thank you. One thing that came up yesterday, one of the other PACHA members remarked that Charleston doesn't feel as rural as he thought it would be. But Tony explained to us that much of West Virginia, a large percentage of Appalachia is rural, and a lot of it is very challenging to reach, particularly the hollers, I guess, and she was trying to explain the hollers to us, and it's fascinating. And so the question really is, what challenges you see in dealing with the rural communities, what experience you've had, and what approaches that you've taken that have been successful to address that population?
Yeah, I'll jump in. One of the silver linings of the COVID epidemic is it forced us to enter the space of telemedicine and telecare. There were several barriers to doing that before. We were at West Virginia University, we, for about 10 years, had been doing some telecare to some of the southern counties in the state, and telepsychiatric care and tele-addiction care as well. So we had some experts who were pretty well adept at doing this and making it work successfully. Barriers such as somebody like me who did not want to do telemedicine, patients who did not want to do telemedicine, payers who did not want to pay for telemedicine, And then hospital systems or clinics who did not want to set up everything with telemedicine. All those barriers were removed within the matter of 2 weeks after shutdown, okay, in mid-March of 2020, right? And so there are so many areas that people live that they cannot drive the required amount of miles to get to treatment. Being able to provide treatment directly to where they are through virtual care has been a godsend, truly, because we've been able to increase access and get people the care they need. You know, one of the things with Appalachians is that they are so incredibly creative. And so obviously you don't have a lot of places where there's even internet. But what we found was people would drive to the nearest McDonald's, and they would park in the parking lot and be able to pipe in their internet through their car, and we were able to provide them treatment there. So whatever we can do to expand and remove barriers for virtual care, this is going to be really the wave of the future in helping create access.
Thank you. I would also say, and we learned so much from the COVID epidemic, and one, we had, you know, sort of vans going all over to test, and Reverend Patterson was very helpful in that. But there were two things. Number one, you can think you know where to put a van, but unless you are working with people in that community that are trusted, and you may have what you think is the most obvious place, it's like, no, you need to go at the holler and turn left for, you know, and so you can't sit in Morgantown or Washington and think you know what you're doing. It has got to be the people there, because they really do know. And secondly, you really have to have the communities in partnership. There was a communities of color, you know, early on in the COVID pandemic, West Virginia was sending the National Guard in. And, you know, Black communities, that probably wasn't the best way, but, you know, with his leadership, sending, you know, culturally competent, you know, sort of folks in on vans that knew their communities were really good. And I just want to say, this may feel like a city, but the 3 cities in West Virginia are all 50,000 people or less. And I will take you, you know, 2 miles, and it'll be the most rural place you've ever seen.
One thing that we've done at our church was to allow seniors to come in. We have a group of computers. We have a computer lab, and they could come in, and if they needed to be in a private room, they'd be there to do their telemedicine. Or it was like a broadcast at WU or Marshall 1B that we felt the community needs to hear. They can come in that setting and sit down and hear those things. But just to make, and a lot of our seniors, which I'm a senior now too, and I got kids that my grandson is still talking about me because I got AOL, but so I got Gmail too, but AOL just feels good, like that good old pair of shoes. But a lot of our seniors don't know how to use and get on these programs, so we supply a thing where they can come in, set an appointment, come in, get on Social Security, see their doctors. Of course, we make them, or we sign a waiver that whatever we do, and I know Reverend Patterson do the same thing, whatever we hear, it's dead from there. Don't go out that door. But it's just another way that we can get our people communicated. Everybody can't get on the bus and go uptown to the hospitals.
Go ahead, Reverend Patterson.
Well, we put funding in our grants when we got funded to do vaccination and testing across the state to actually have 24 community health workers. So they were primarily responsible because they knew the community and what have you. And so when that started coming to an end, we had the community health workers trained on prevention as well as peer support. And so the whole goal was that, okay, now we're going to use this network of community health workers to address the stigma around substance use disorder and challenges, because they would know, for example, who probably know more than we would, who was positive in the community, and they would have the knowledge on how to approach the person, or also how to do prevention in the community among the young people or whoever else we wanted them to do that. And so that network of community health workers are ready to do this. So all we're doing now is waiting for the funding to do that.
So I will say that I think I want to expand on what Sally said. It's really important to involve the people in the community. First of all, they know their community, you don't. And you have to listen to what their, long experience is about how to go about things and where to place things. Another aspect of using people in the community is we have found it very important to involve peer recovery coaches. That's the West Virginia technical term for people with lived experience who can help you. And we wind up making them essential members of all the studies that we do, because again, you need people with that direct expertise who are going to be able to reach out and tell you that's not how we do it. And I'll tell you an anecdote. When the CDC came in to do the EpiAid on the first outbreak we had, which is called the Southern Counties Cluster, they commandeered space in local health departments. They didn't involve the local health personnel, and they could not reach 25% of the people who had been identified as HIV infected. And when we talked to people in these health departments, it turns out that nobody asked them. They said, these are people who've lived in these communities forever. Like, oh yeah, Mr. Smith, that's like 2 hollers over and up the mountain. I mean, they know where people are. And, so it was kind of an interesting situation that the CDC didn't avail themselves as they could have of the local knowledge. But I think that in rural environments, right, you're an outsider until you've proven yourself, and then you're an outsider with credentials, but you're still an outsider. And I always joke about it because I have this incredible New York accent. People go to Southern West Virginia and people say, well, you're not from here. You betcha. I'm not from here, but I care about you, and I'll do what I can to help you. And that's a very important thing. That's probably true of rural communities nationwide, not just Appalachia. But, part of Appalachian culture is fairly clannish, right? You have communities that live on hillsides that are multi-generations of the same family. They're very tightly connected. And, outsiders in this state have often brought problems, not solutions, right? So, you have to stop and think about how this is a state that has been raped over and over for its natural resources, right? For its coal, for its timber. And that the wealth that generated didn't stay here. So I think there's understandable anxiety on the part of a lot of West Virginians for outsiders coming in and saying, oh, we'll do this. No, the people who came in and said, we'll do this didn't do us a great deal of goods. Being respectful of these communities and engaging them and listening to them and accepting their expertise, I think is very, very essential to doing any kind of work here.
So thank you. That's a wonderful transition. So I'm Vincent Ramos. Just to remind everyone again, we have been talking about sort of the context on the ground. And we've all enjoyed the conversation and really hearing from the experts that are here in West Virginia. We want to pivot a bit. We want to ask the panel to please talk about solutions. And we're really curious about specific things that you each might recommend in terms of how can West Virginia better support and respond to the HIV epidemic.
I'm going to jump on that, Guillermo. Okay. First of all, I understand that when they started the EHE, West Virginia, probably we had only maybe had the Southern Counties outbreak and it was still small. So one of the questions I have for the federal system is, how come you don't reevaluate what states and what communities could benefit from EHE resources? This is a resource poor state, and we need everything we can get from everybody and everywhere? How come we have our HIV incidence is more than doubled? How many other EHE designations have a rate that is more than doubled? So we need to be part of EHE. We need that money. We need those resources. That's A. B, from a federal perspective, the most expensive thing in a syringe service program are the syringes. And you cannot use federal dollars or block grants or anything that originates in Washington and comes to Charleston, West Virginia. You cannot use it to purchase syringes. So how come that is not addressed? I understand it's a congressional issue, but if you make that recommendation, maybe Congress will act on it. But syringes eat up a huge part of the budget, alcohol wipes and dental cottons and, all those other things are pennies and syringes are many dollars. What else can you guys do? I've been waiting to say these things. I think the other thing which is really internal to us is that we have Dr. Christensen was extremely generous in his description of the political situation here. But before Senate Bill 334, there were 16 syringe service programs in the state, and after 334, there were 8. Right? And we have the highest overdose fatality rate in the nation for over a decade. And we are 40 points above the second state. And we've been first or second highest state for acute hepatitis C for over a decade. We have the highest rate of acute hepatitis B for over a decade. This is all tied to injection drug use. And we have a legislature that just does not acknowledge that and only wants to be punitive, right? Only wants to be punitive. I wish federally you could do something about that, but it's hard to even think about the problems here without thinking about the commitment of the people who run this state politically and what the hell they think they're doing. Because as a physician, to me, these are lives, right? These are lives. It's incredible to me that the elected people here don't see it that way.
I think what we need to do is to redefine or accurately define equity and act upon it as it relates to challenges that we're facing here in West Virginia. I did some study at a small unknown graduate school in West Virginia called Future Generations. And as part of the program, they had demonstration projects in India, Nepal, Tibet, Peru, West Virginia, upstate New York, and probably someplace else. And you had to go to each one of those demonstration projects for 6 weeks, except me, I had to go to India twice. But anyway, while I was there, I met a young man by the name of Manoj. And he lived way up in the mountains. He and I would sit up late into the night arguing over equity and what it was. And it turned out that he was right and I was wrong. I was like a lot of people in the West. I thought equity was equality. That's what I thought it was. And so even in the president's release of funding that came directly from the president, he said there was a line in there that says everyone needs to have an equal access at this funding. That's not equity, because if you give Sally and I equal access at funding,
oh, you're going to get it.
No, I'm not going to get it. I'm not. And it's so he said that equity was applying the largest amount of resources to the largest amount of need. Applying the largest amount of resources to the largest amount of need. Let me give you this. The infant mortality rate for Black babies in West Virginia is 13.7. For white is 6.8. In Russia is 4.8. And in Ukraine is 7. Y'all want me to say that again? Yes. Okay, the infant mortality rate for Black babies in West Virginia is 13.7 per 100,000. Is that the number? Okay, and for whites, it's 6.8 In Russia, you can't believe what Russians say, but in Russia, it's 4.8. It's 4.8, but I do believe what Ukraine says, and theirs is 7. And so infant mortality, all of you all are medical professionals. We know that infant mortality rate is one of the factors that we use to judge the health of the population. So if we're talking about health equity, we need to be talking about, okay, these organizations such as PAC and such as Bishop Haley and such of these organizations that are trying to do something, we need to be funded. That's what needs to happen. You know, what can you do? You can fund us. I just said that we have 19 community health workers that are ready to go out through these communities. They can do anything that we train them to do, particularly around this issue. They know who would have HIV in a small, isolated community. They would know. So what we need to do, but it's going to cost me $800,000 to run this network for a year. So what we need to do is we need to reallocate funding in those communities and in those situations that have the largest amount of need. And it doesn't matter what you choose in terms of measuring. People of color are going to have higher rates in most instances than other populations. So that's my minute sermon for the day.
One of the reasons why we started a health fair was our what we do in the medical field is the fact that our people were not being taken care of. And when I say my people, I don't mean just people of my color. There are people around West Virginia, and let me give you a little definition right quick. I was listening to some of y'all talk about hollers, and these people over here was looking at you. A holler is a road between two big mountains. And that's where the community used to holler from house to house. So that's basically what a holler is. But there are so many people around here that are doing great work. People have to get out of their offices and come down and see what's working. That's the main, just see what's working. Then when you see what's working, fund what is working, you know. But I got a little thing about studies. I remember in 64, young kid in junior high school. I remember watching news with my mother, and they said they were going to do a study on the west side of Charleston. They've studied the west side of Charleston so much, and I've never heard anything come out of it. I mean, you got to come back to your people. Anytime I make the decision, anytime we say we're going to do something, we're going to do it. And if we can't do it, we're going to go back to those same people, let them know we can't do it. Because then the pressure's not on them and the pressure's off of us. But anytime we do it, we've got to keep our word. That's what the government has not done. That's what not just the federal, but state, county, and city has not done to the people here in West Virginia.
So Bishop Haley and others, I'm going to invite you all to really focus in on trying to help us crystallize the solutions. I appreciated very much Dr. Feinberg's comments about EHE and the sort of prioritization of West Virginia, the syringe exchange programs. I think those kinds of comments are really very specific, and they allow us to understand what might potentially be helpful.
And I really appreciated, I mean, you know, the work that goes on. But one thing I can say, what's a solution for the federal government? Mm-hmm. So if you will start broadly, we talked about rurality. If you look at the 23 states that are called Institution Development Award, they don't get NIH money. They have less than 10% of NIH funded studies. Now, this is in all areas, but less than 10%, and the funding is less than that. You got about $5.5 billion that goes into funding clinical studies, clinical trials from NIH. In those 23 states in Puerto Rico, it's $0.4 billion. And, you know, many of us have been a part of the DAIDS networks, the ACTG and HPTN and other lives. Well, today,
those networks need to be putting studies in areas where you have the biggest increase. Now, we're under consideration only because Feinberg and I have big mouths and have been yelling for the last 3 years, and we may or may not get it. Dr. Kilkenny made a very sort of I think, true statement that the PrEP, with a pill every day is not going to work in populations that are homeless, that have chaotic lifestyles. But there are real solutions on the horizon, like lenacapavir, right? 2 sub-Q injections every 6 months. But if you don't put those and look and see if they work in the populations here, and what do the communities and the people there think about it? And are they going to believe the science? I mean, we've recently had experience with fabulous science. And, why should somebody sitting, I don't know, in the holler believe what's saying in Washington? Did anybody come and engage them in the studies at all? And so, I think that there are reasons we need to get these sort of what I think are frontier breaking therapies tried here. We need to put monies into clinical trials. And as everybody has said, it's not, just funding a clinical and translational science institute in Morgantown. It is actually the funding that has to go out to the community health workers, community research ambassadors in those communities, because that's where you're going to get belief and get traction, but it isn't free. And so I think, that is something that could really, I think, at a federal level, focusing sort of effective research here with some of the new things coming is important.
No, I think Sally is 1,000% right about that. If you think about ever since the outbreak in Scott County and sort of the wake-up call that there's HIV in rural America, but all of the clinical research is absolutely focused in urban America. Like, bring some of those resources here. As I said before, this is a resource-poor state. The Bureau for Public Health here has a handful of people working on HIV and viral hepatitis. I think it's not even 4 FTEs. Come on. There needs to be resources sent here. We need them. We just need them.
The other thing that I think I would add is that here in West Virginia, we pretty much live in a mental health care desert. We do not have enough healthcare workers who are equipped and skilled to deal with mental health. And it's a severe shortage. Addiction is a mental health issue, and addiction and HIV, AIDS, other infectious diseases are frequently co-occurring with other mental health issues. And we need to be able to be well equipped, and we're simply not right now. So trying to look at mechanisms by which we can train and keep people in the state. A lot of people are going out of state who are professionals. We do have a brain drain. We don't pay them well. And so how do we incentivize people to actually get training and stay in the state and then make it profitable to stay in the state as opposed to going elsewhere? Specific example, when I think of psychiatry, for instance, like Judith said, we do not have enough psychiatrists in the state of West Virginia. And if we can help fund training programs and residency programs, et cetera, to be able to do that, that would be one tangible mechanism.
I couldn't agree more with that. And that's one of the things I was going to bring up is we currently meet the need of 8.7% of the mental health needs in the state of West Virginia. So it is the lowest ranked mental health provision state in the country. So of all of the needs that are being offered, 8.7% of those are being met. And when you look at trauma and its role on all of the sort of risk factors that can lead to infectious disease and substance use, it's obvious where it comes from. And so at some point we have to get upstream, and we need to be looking at funding prevention. We don't fund prevention. Community health workers have found a mechanism for payment through some pilot projects that were funded by the Appalachian Regional Commission. But at this point, there's no funding for a prevention worker to go out into the community. That either needs to be done through, CADCA or other organizations, but it's not just something that a hospital can employ in the same way that we now can employ a peer recovery support specialist. So why not have prevention advocates. Again, those people on the ground who know it. They know it better than anyone. They know where those people are. They're the true experts. I think also on Reverend Patterson's point, the idea that many of the grants have limiting language, which precludes potentially Reverend Patterson from receiving that when in direct competition with a larger institution. And that's limiting language in the fact that we often limit it to a drug or we're still writing grants for opioid treatment. I need methamphetamine treatment. And we don't need to limit it. Every time we silo our impact, we are siloing prevention, we are siloing treatment, we are siloing partnerships. Our greatest success has been when the state has dropped money and an organization has approached us as a larger institution that has grant writing and fiscal, the ability to observe a grant. And we have said, we will partner with you. We will do the work. You do on the ground. I'll take care of that grant report, but you go serve the people. And so if those partnerships are allowed because the grant has language that includes direct care services and is broad as possible, and I know people do not take responsibility for it, but in Appalachia, we're going to. I mean, the 6 of us know what's going on and are going to hold people accountable. People squealing real quick when resources aren't being used. And then lastly, I would just argue that we need more systemic payment structures. So when treating women in treatment, I am treating mom and I'm eating the cost of 4 kids. And they're costly. I have 3 little hooligans running around right now that my phone's blowing up about that we got reunified with a week ago that were dropped from the other side of the state with nothing, right? I need to get them ready for school. Where is that money coming from? And so systemic payment structures and dyadic payment structures would be really great as a way of engaging both individuals and their partners in care. And I know I said lastly, but actually most importantly, I would argue we need to figure out housing. So people need low barrier, safe and supportive housing. If they are released from a treatment program or they're released from incarceration and we expect them to do well on the street, without any psychiatric medication, without any primary care treatment and referrals, why would they not continue to use? I argue that most of the individuals in treatment are 10 times stronger than I'll ever be, because they found their way through the madness into care. Whereas I wouldn't last 4 days on the streets of Huntington, and I know that. And so people would use drugs. They would use sex and other activities to engage in something that's going to make them feel not sick and isolated and alone. And if we don't understand that normalized process, then we're just not being realistic with the disease.
So thank you to the panel for those very specific suggestions. I want to pivot a little bit to workforce. And so I know that's a topic that has come up, and Dr. Berry was just mentioning this. But I think what was really profound about yesterday, and we visited a number of sites, and it was, for me, it was quite profound. I think one of the things that I saw a number of pharmacists, I saw a number of social workers, I saw many nurses. I saw a clinic that was headed by a nurse. I saw an LPN. I saw many healthcare providers that were not the traditional physician providers. And so I want to talk about some of these needs in the behavioral health space, in the addiction space, in the infectious disease space, and how this panel envisions solutions to the issue in West Virginia.
So trained and committed healthcare providers are in real shortage, no matter what their specific specialty is. Part of it is you have to attract people to live in rural areas, and probably the majority of people who go to nursing school, nurse practitioner school, PA school, social work school, whatever, medical school, are probably not from rural areas. And so that in itself is limiting. Our neediest counties are needy in so many ways. So McDowell County, which is number 2 on the CDC hit list of 220 counties at, high risk of an HIV outbreak, does not have a grocery store. Also does not have a syringe exchange program, right? And then pulling skilled professionals into a community where the local support, like the syringe services, which is essential, and where you can't buy a head of lettuce unless you drive a county over, is a hard sell. And I think You have to be realistic about that. How would you like to live in a county where you can't buy a head of lettuce? These are people who get their nutrition from Dollar General. This is not good. Okay. And this is not health promoting so I see from having spent a lot of time in these communities, kind of what the issues are. They're obviously far more global than what PACHA can do, but you need to understand sort of what that context is. I would also say that a significant amount of the primary care here, and I don't have numbers, so I can't give you statistics, are really provided by nurse practitioners rather than physicians, which is fine. So I don't have any quarrel with that. But that may be, continuing down that path may be the way to pull more skilled providers into care. For example, HIV care, right? The Ryan White clinics are all in the towns of 50,000 or less. Sure. I've lived in suburbs that have more than 50,000 people. So, but HIV is dispersed, right? We have an outbreak in Mineral County, which connects the Eastern Panhandle to the rest of West Virginia. Probably most of you have never heard it. Maybe even lots of people in West Virginia not very familiar with Mineral County, but we have an outbreak, a cluster, because they're linked genetically, 7 homeless people who inject drugs who have HIV. And there's no syringe service program in Mineral County, right? And, how are we going to provide care for those individuals, right? So all of the care, the Ryan White, we need a system where, let me just say it this way. We need a way so that the wonderful things that Ryan White provides, the wraparound services, all the access to additional care, dental care, mental health care, we need a way to decentralize that so that people who are getting their HIV care in rural communities have access to those resources. Because having worked at Ryan White clinics myself for decades, I know exactly how useful that really is. But if that's contained to Morgantown, Huntington, and Charleston, that's not going to help enough. So we need a way to think about expanding the Ryan White net more globally.
Actually, Judith and I are authors on a paper in The Lancet that said that 3 years ago. You really need the wraparound services for folks, with substance use disorder to connect them to all the various things. So that's number one. But number two, the primary care providers, whether they're nurse practitioners or physician's assistants or physicians who do live in these communities, are very connected to those communities and very dedicated. HIV treatment today is not rocket science. And I tell them all the time, what you'd have to figure out with diabetes, which I don't know anything about that today, and hypertension, HIV is much easier, just get to know it. So I think telemedicine, and there have been programs, I think that, the ECHO programs, and we do have an HIV and a hepatitis C. Hepatitis C is really easy to treat, and there's no reason you can't do that. And then really sort of have the connections. And the great thing about West Virginia is it's a small state, and most of us know each other. And I pick up a phone and call you. We really do. And I think that is something that has really not been used. And the other thing, just while I'm on a soapbox, so HRSA has this definition of rural, right? Oh, my Lord. Yeah, don't get me started. Have you ever been to Paw Paw, West Virginia? That is rural in anybody's book except HRSA's. So, when you're looking at, this doesn't qualify as a HRSA rural site, they need, Judith and I'll take them on a little road trip.
Right. Actually, it's problematic. The federal government has 5 or 6 different ways to designate rural, every agency, everybody that's got a cabinet position, or the sub agencies and HHS, everyone's got a definition, and they're not consistent. And grants require that you meet these criteria, and it is insane, the HRSA criteria. It's absolutely insane that you can be in a community of 300 people, but still within 50 miles of Charleston. But no one's getting in the car and going to Charleston. No one's got a car. No one's got money for the gas. You know, and that's something that PACHA could do.
Thanks, Judith. Getting back to your original question regarding the workforce too, and it echoes some of the things that have already been said, but we certainly don't have enough specialty care, and we may never have enough, psychiatry specialists, for instance, in the state. But, I see two-prong attack. One is try to equip the current primary care providers, whoever they may be, and Lynn's done some of this work a lot, whoever they may be, whether it's nurse practitioners, family docs, et cetera, who are actually in the communities, give them the tools that are necessary to provide some degree of specialty care up to what they can with the support of specialists in the state. So how do you magnify, for instance, my reach among the primary care community? And there's various ways to do that, such as the ECHO program and other things. Another model of care is collaborative care model. That CMS has payment models on how to provide. Actually, you have a specialist who has access to a primary care clinic's cadre of patients. The primary care provider is the one who's actually doing the treatment, but they're doing so in regular consultation with a specialist in some other institution. And some states then are able to pay for that. But here in West Virginia, we don't have those payment models yet. So if there's anything that can be done to advocate, for instance, the collaborative care payment models, that's another wonderful way to try to address the solution. The other prong would be to train nurse practitioners, family docs, PAs within their respective training programs in addiction care, HIV/AIDS care as well. And the only way that we're going to ensure that happens if there's federal mandates as far as credentialing programs, that this is a required exposure that you get. And right now, it's just not happening as much as it should.
It's an important part of our Hep C, HIV, syndemic, because we put them together, elimination plan, is reorienting or revising healthcare professional pre-graduate, so classroom instruction, and then at the clinical training postgraduate, that these things are addressed to. And so a federal mandate would strengthen that, because, lots of program directors may be, you have to drag them kicking and screaming to do that. But, you should not be able to have a medical license, a prescriptive authority in West Virginia, and not know how to prescribe buprenorphine, and not know how to diagnose hepatitis C or HIV, and not be able to cure Hep C, which I have a program that we've consulted on 1,200 people over 3 years. All of the people in this program are primary care. 22% are addiction care providers, and the cure rate is 98.7%. It's doable, right? It's doable, but it needs support, right? And now we have a new program to do the same thing for HIV. But, federal muscle goes a long way to moving things at a state level.
So we have about 30 minutes before we're going to wrap up. We're going to leave time for questions. I'm just going to pull in Bishop Haley and Reverend Patterson, and then I'll jump into you. But Bishop Haley, you mentioned that to start, when you introduce yourself, boots on the ground, use that language. And so I'm curious, in terms of solutions to meaningful community engagement, the folks that are not able to access our services, what thoughts do you or Reverend Patterson have about meaningful community engagement?
Okay, a couple of years ago, we actually partnered with Health Right and CEG to do mainly during the pandemic. We were getting tested and also providing vaccinations for the pandemic, but also we were gathering information about AIDS and all the other things that were out there. What we did, we provided food. Everybody likes to eat. And in a night, we would do 60, 70, vaccination, or not some of the interviews with people. Some were getting vaccinations, some were getting testing and all this other stuff. And the majority, we do the food distribution. Our food distribution, they fill out a form, and at the bottom of the form, They state anything else they need, housing, electric being paid and all this stuff. So we can gather more information, trying to get money to our area so we can help these people. A few food distribution, we've fed over 17,000 boxes of food in our 4 or 5 years we've been there. Every time we feed them, we're sending out information with those boxes about anything that's going on in the community. Like I say, Health Rights, CG are great partners with us. So we're sending out information to these people, phone numbers, contact people and things like that, so that people know where they can go to get the help. Our phones ring off the hook all day and all night about, various needs in our community. And so we answer every call. We try to get back with everybody. And it does take an effort. You got to realize all this is done by volunteers. So our main thing is that if you have a need, you call us. It's our requirement, it's our obligation to get back with you and try to solve that problem.
Thank you.
Well, we actually had people that would actually go to people's houses and do vaccination and testing. For seniors, we had one woman that was 101 years old, and we got her vaccinated and tested. In addition, we funded some organizations, we funded some churches to help with the organization, because a lot of churches and a lot of local organizations did not have funding to do that. We also, and I was told to do this, we also had a Dimensions of Prevention grant. So we were doing prevention on a large scale in the communities. Basically, it was a school-based program where we were in 6 schools. We contacted over 2,000 folks, as well as doing prevention in the community. But I think the main thing is you have to be visible, and you have to be able to supply whatever the need is. It isn't always what you're doing that the community needs, but you have to rearrange your programming and whatever, and provide what the community needs, and they will continue to be a part of what you're trying to do, and continue to call upon you for help when there is a need in the community.
Thank you. I think, Lynn, you had a comment.
I just wanted to add, I think if we can embed people in the community, like Dr. Feinberg mentioned, but with paid internships and paid placements. So we have a rural health division of family medicine, and those people stay in West Virginia at a much higher rate than other providers, because they get to know the community. They figure out how to get the lettuce, right? They may then connect with someone to set up a farmer's market. And so people fall in love with West Virginia. Did I think I was going to be living in West Virginia? No. I'm from Northern Virginia, so I'm the other Virginia. I'm the one near Richmond, not this one. I think having been here, we fell in love. We said we were either all in or we're all out, and we are all in. And most people, I think, find that way when they get here. I'll never be from here, ever. I'll just be sort of accepted here. But if we can get students engaged in the community, they too can fall in love, and then they get that on the ground training. But we need funded placements, because we cannot continue to rely on mental health providers who have gone to school, have taken those college degrees, have taken those master's student loans, to then not be paid for their placements and internships. And then second, I would just add that we need to advocate for those with lived experiences to get the credentials that they can be reimbursed for their services and be embedded in the workforce. And that involves advocacy at both the education and employment level. And so we try and advocate through our core program, meeting with employers to say that an individual in long-term recovery is an excellent asset to your organization, and you can take them on and maybe pay for some of their schooling or placement. And now you not only have a credentialed social worker, but you also have someone with lived experience who can really meet all of those needs for you. And they're going to stay here because they care about their community. And so that engagement, both to make an employer a recovery-friendly workplace and an education system a recovery-friendly entry point, is essential. And the West Virginia Chamber has partnered with us on that. And there is now a workforce toolkit on the homepage of the Chamber office that anyone in the state can take for free to learn about how to become a recovery-friendly employer.
And one thing that we're doing is we're on the west side of Charles, and Reverend Patterson, a lot of his facilities are over there. We're in a food desert in the capital city, in a food desert. We have a Kroger's close to us, and next Kroger's, then this supermarket is 10 miles away in Dunbar or whatever. So what we did within our community, we have a young man named Darrell Miller. He's opening up his own grocery store there. He's growing his own food. He's doing his thing. So we're not sitting there. Now, don't get me wrong. We need your money. Go ahead and say it. But until we get the check, we gotta make some things happen. And I think that's Reverend Patterson's thing. It's my thing, and it's others, that we've got to make things happen for our community. And we can't wait for politics to shift, for people to start caring about people. We don't have a political problem. We got a heart problem. People just don't care anymore. And if I could sit in D.C. or somewhere else and make decisions for everybody else, I'm kind of shielded from the effects of it. So, but we try our best to heal ourselves within in there. But we're just blessed to have a lot of good partners that help us.
Thank you. With that, I'm going to open it up to PACHA members for questions. And so I see Dr. Shag.
Thanks for the dialogue. It's very inspiring on one level and kind of overwhelming on another. I'm trying to understand what the day-to-day life is like, and for people that are engaged in a situation where transmission might happen. I'm imaging sort of the Scott County situation where someone in a family acquires HIV or hepatitis C. And then if within that family there are other people that are sharing works, that it spreads quickly, I would imagine, through that household. Is that the type of situation you observe? And if so, every time I hear you say community-based, I'm thinking about people going to someone's home, almost like case contact tracing, and trying to intervene right away to prevent transmission in that household, or at least screen and see how many people are affected. Am I imaging this correct? I'm just trying to get a sense of the landscape in the micro level.
So, Mike, there is intergenerational drug use here. I think there's been a fair amount of despair for a while in West Virginia, which I think feeds the escapism of substance use disorder. But and I think reaching people where they live would be very, very important. I don't know that the intra-family dynamic is dominant or the most important part of our epidemics. I mean, I think it is a piece of it, but I don't know that I would say that. I don't know, Lynn. I don't think I would say that it's the primary driver. I think a lot of the people I've seen are young adults who are homeless and do not have children, they're not living in any kind of nuclear family setting. In fact, the sad thing is how many people are not living housed in any setting anywhere. But I don't think that's the dominant picture here.
I'll say from the qualitative interviews we did on the 88 women, and I'll just sort of, the context of this was a study that was done in 2012 in 6 urban centers. And, that was the HPTN 064. So when I came from Newark, we took that. And I got to tell you, one of the major themes among women who were using substances was the isolation. I mean, they really felt very isolated. Much of that was stigma related. Some of it was violence against women, which we haven't talked about, but is an important problem. And, it's a problem everywhere. It was a problem in Newark, New Jersey, for sure. I mean, if I need a roof over my head, I need food for my kids, and I need to do what he says. And I'll never forget, one woman said, my dad actually brought me here and we made an excuse because the guy she was living with didn't want him to talk to. And I don't know this for a fact. She said she was HIV positive. So, I think that there, as Judith mentioned, I think it's not one size fits all. But I do think that we sort of look at this as, the HIV epidemic. And I think an important piece that is often missed is really focusing on women. I mean, we heard this morning 65% men, but women are so important. They often don't know about that. And those are special programs, and they're isolated, at least based on what I know. And that is really going to take all the community resources that really know where these folks are, but also making them obvious and available. I mean, this woman came, sort of schemed to get here to talk to us, when we did these interviews. So there is just much, much more to do there. And the intergenerational drug use, I never heard that when we did this in Newark, and it was a theme here. But I don't think I agree with Judith. It's not the predominant way.
So we have about 20 minutes and we have 9 individuals. I just want to acknowledge Carolyn because I did not have this list. So thank you, Carolyn, for having the names. So I'm just going to go in order. If we could maybe try to answer their questions in a sort of abbreviated way. So Dr. Hansel-Tooth, you're first.
It has been an absolute honor to hear from all of you, particularly as a city physician. One thing that I heard a lot about was about recovery. And I was wondering, within your state and within your programs, what is the acknowledgement that some people don't want recovery? Some people want to continue using substances. Judith mentioned the word despair. We know opioids are fantastic at treating physical pain, but they're also fantastic at treating mental pain. Some people don't want to stop using substances. And since this is addressing HIV and substance misuse, in order to actually end the HIV epidemic here, there has to be an overwhelming acknowledgement that some people want to, and some people are going to continue using substances. So what have you done? I've heard a lot about harm reduction and meeting people physically, but what are you doing within your programs to meet people mentally as well, and acknowledging the fact that some people are going to continue using substances?
I know with the things that we're doing, like I said, we have recovered girls coming to our church 5 days a week. And what is missing basically on the west side of Charleston and in West Virginia is most folks have lost hope. They don't have the coal mining jobs they used to have. A whole lot of other barriers have come up. And so you get into a rut where the bottle, the drug is my way of checking out for a few hours. Be honest about it, the most motivation you get in West Virginia is either W or Marshall football games and things like that. Everybody gets up for those. But the thing of it is that we got to teach the next generation that this don't have to be your world. You don't have to leave here. But with technology now, you don't have to leave this state and make things better. But I think overall with the political scene and with other things going on, a lot of our people don't have hope to ever be out of that situation that they're in.
We have a drop-in center as well as a therapy center. So normally the folks that you're talking about are people that come to our drop-in center. I mean, and they know and we know that they are using, and we offer them whatever we have. Sometimes they're just coming to get some food, or they're coming to get something to drink, or they're coming to get a bus pass, or whatever their needs are. So to answer your question, we work along with folks, and we continue to let them know that treatment is available and what have you. And if they accept it, then we will help them get into one of our facilities or another facility. But if they won't, if they're not ready to accept a treatment or enter into a recovery program, then we just continue to work with them and provide whatever we can provide until they decide that they're ready to enter into treatment. That's what we do.
I'm going to move us forward with Dr. Philip Chan. Your question?
So thank you so much for sharing your experiences, and thank you in general for all the work that you do. I'm an infectious diseases physician up in Providence, Rhode Island, and a few of you touched on this. I think to fully achieve the goals of ending the HIV epidemic, right, we really have to engage the primary care community. So I'm wondering just if you can touch on access to primary care in West Virginia, and specifically related to the equity issue, what folks do who are uninsured, thinking, for example, for the young males that don't have insurance. Theoretically, right, there should be a network of FQHCs that exist through the state that provide some of that safety net care. But can you talk about access to primary care in general, and even some of the more rural areas and what that looks like, and any thoughts on if people even engage in primary care in general?
There's tremendous reliance on FQHCs in this state. And of course, if somebody crosses your threshold, you have to take care of them. And I think that's the way a lot of people in rural areas access any kind of care. Now, the real issue is what they need. Is what they need at their FQHC. Is there harm reduction information? Is there treatment for substance use disorder, if that's what they want? Is there screening and evaluation and treatment for HIV and other diseases? And that's a lot of the work that I've been doing, is to try to get that to happen. But we're nowhere near have we scratched the surface to do that. So I think it's a real concern. I mean, Jim has taken care of people around the state with substance use disorder. I think he can speak to that.
Yeah,
too.
I think Lynn will actually have a better answer when it comes to primary care. But I will say that in West Virginia, frequently the de facto treatment site for primary care is our emergency departments. And many of our emergency departments are absolutely overwhelmed with people who are suffering from mental illness and suffering from addiction, which is also a mental illness. And so these often clog up the hospital system and create a whole bunch of downstream problems. So again, the strategy is, how do we go about reaching those folks before they get into an acute crisis where they find themselves having to go to the emergency department? But much of our primary care, unfortunately, is taking place in emergency departments.
So Paul Kawada, you're up next.
To the panel, I mean, you're going to hear from everyone. Thank you so much. It was really very, very moving and very powerful. My name is Paul Kawada, and I am the executive director of the National Minority AIDS Council. And Reverend Patterson, I couldn't go forward without acknowledging what you shared. And I just wanted to say I'm sorry. As a gay man of color, I felt your pain. You know, this world is a very, very tough place that we live in right now. And I will be honest, I had a bias about West Virginia as being 97% white. And so how do you talk about race in the state, and how do you bring the equity issue into the room when you are so overwhelmingly white?
I just do it. You know, I came to West Virginia when I was 19 years old to go to technical school, and I'm 71 now. And so I say that there isn't much that folks can do to me that they haven't done already. So I just let it all hang out and just say, you know, that, you know, we have folks who are living with challenges, you know, and so I'm not ashamed, or I'm not fearful to just say, look, this is what's fair, and we need to provide services to these folks. And it's hard for a person to tell me no 10 times or 20 times, but that's what they have to do if indeed the resources are there, the resources are available, the resources are meant for the person that I'm talking to you about, so that, you know, I don't mind doing whatever we need to do in terms of being persistent to try to help some folks. And so that's what we do. You know, just because one door is shut, we don't stop. We go to another door. We try something else, and things are starting to move a little more quickly in terms of what we're trying to do. And I just talked to these two institutions here about us forming a partnership on some additional things. We've worked together on things before, and so we're going to work together on some additional things, particularly in terms of trying to get these facilities that we need built and up and running.
Thank you. Carol Treston.
Thank you all. That was really enlightening across the board. My name is Carol Treston. I'm with the Association of Nurses in AIDS Care. And I want the name of that nurse practitioner, please. I'll have a conversation with him. But I do want to point out that West Virginia is one of about a third of the states in the country have full practice authority for nurse practitioners, and West Virginia is one of them. It's a remarkable achievement, and we're going to hear from some nurse practitioner-led sites this afternoon. And I'm wondering if there are 40 nursing schools, different levels, associate's degree, RN, BSN, masters in the state of West Virginia. And I'm wondering if there are any members, how are you engaging the nursing education community that might then lead to the pipeline of nurses, nurse practitioners staying in the communities that need service? And then secondly, the fact that this is a full practice authority state, coming from states that don't have this is a model of a place to work. And so thinking about how to attract, and again, yes, there'll be outsiders, but committed outsiders that will eventually, hopefully, become accepted. But the fact that this is a place where nurse practitioners can really practice to the full extent of their licensure and education, and we'll hear about that today. Thinking about how to bring folks in. And then secondly, also that engagement with nursing schools could lead to the greater provision of services by registered nurses. When I think about MAT services, et cetera, really RNs can handle that. And so how are there strategies to engage nurse educators in these efforts that will then develop the pipeline?
A partnership through WVU, Marshall, and the Osteopathic School around a MAT education grant that was provided to embed MAT education into all of those medical curriculums was then expanded to the nursing programs and offered to them at those schools. Secondly, there's an outreach in the third year to the other nursing schools in the state. It's also an effort to work with the state nursing board and the sort of leadership in the Higher Education Policy Commission to ensure that education efforts that we're providing to any provider are also directly provided to nursing staff. And so, for example, nursing was one of the teams on the SBIRT grant. And so Marshall Nursing was one of the PIs on that grant, so that we were ensuring that that curriculum was then embedded in the longevity of that program and had greater sustainability after the grant. The other way for direct practice providing is at PROACT, our provider response organization for addiction care and treatment, that low barrier access point. We rotate most of our providers. We only have 2 full-time providers there. All of our other providers are moonlight. So you could be an ED, see people recover and not just the overdose scenarios. And we have 2 of those. And they come work a half day. We have a nurse practitioner. We have 3 nurse practitioners come work a half day or a full day. And so that they don't have to just become a substance use treatment provider, but they can still be doing their day job, for example, and then be engaging in that. So they're getting that care and treatment. And then when they go out, they can provide it elsewhere. Similarly, our nurse pracs and PAs are rotating through with family medicine to ensure that that primary care intervention is including that collaborative care team that Dr. Berry referenced earlier.
Yeah, at West Virginia University, we're fortunate enough that we have a really good relationship with the School of Nursing. And actually within our Department of Behavioral Medicine and Psychiatry, we have nurse practitioner faculty who are part of the program. And so we've got 2, and I'll give you this name, Toni Dicchiacchio, if you want to reach out to her. But she has been a absolute champion in helping not only nurses, but just the community of treatment providers understand addiction. She's embedded in our MOUD treatment programs. We are designated as a center of excellence. And so we actually have a cadre of nurses who come extended longitudinal time within our various levels of care, but especially our MOUD treatment. So they get to see it and really live it out and see how the patients respond to it.
Yeah, just really quickly, our practice-based research network, with 131 sites all over, the co-director is actually and we really sort of embrace the nurse practitioners who are doing many wonderful things really in the research networks as well.
Thank you. Jesse Milan.
Thank you all for this truly inspiring panel. We've all learned so much, and we've been so inspired by your work. I'm Jesse Milan, and I'm the CEO at AIDS United, and AIDS United has run for 20 years the Syringe Access Fund, which has provided private sector funds for syringes. But Dr. Feinberg, you make a very good point that the federal government's ban on the use of federal funds for purchasing syringes is part of the problem. So I'd like to know, what is the advocacy that you all are doing with your congressional delegation to remove that ban? And then second, for all of you who are practitioners, tell us, what is the readiness for West Virginia for supervised injection? Is that a strategy that you're developing?
Jesse, I think that West Virginia is so far from a supervised injection site. I don't even want to start there because, as I said before, we had 16 syringe service programs before Senate Bill 334, and now we have 8. So the state structure is moving in the other directions. And I think supervised injection is like not only is it not on the table, it's not even under the table. As far as advocacy goes, this is something that on behalf of the Infectious Disease Society of America and the HIV Medicine Association and the American Academy of HIV Medicine, all these things I've been part of, I go to the Hill at least annually, if not twice a year, and talk to all of I know all the staffers by heart for West Virginia and talk to them about this. But there just has not seemed to be much of an appetite, in Congress to do anything about this. I think a recommendation from PACHA would maybe move that further along than even passionate individuals can. So I really hope that you all think about that seriously.
Yeah, I totally agree with Judith as usual. But listen, you got to understand, it's to evidence-based medicine the way we need to for treatment. So there's a moratorium in West Virginia on the number of opioid treatment programs. We only have 9 in the state of West Virginia as designated by methadone programs by the state legislature. So we far and away lead the nation number of overdose deaths from opioids, far and away. Yet we don't even have access to what is available for treatment that is FDA approved because there's this moratorium. So what I would advocate for is, let's start there. How about whatever you can do to help us move forward with methadone programs and increasing access to that? That was where I would encourage us to start.
Tori Cooper.
Thank you all for your hard work and dedication to HIV, to healthcare, and to people who use drugs. I don't believe that I've heard anyone mention the transgender community anywhere in our meeting today. And we all know that trans and non-binary people are some of the most marginalized groups of people. And in 2017, here, the National Trans Health Survey results show West Virginia is having one of the highest rates of trans youth in the entire country per capita. Many of these youths are now adults. So trans people usually have lower rates of viral suppression and are not highly engaged in PrEP services, which we know. What are your organizations doing to reduce those disparities and ensure that specifically trans people in Charleston and all across West Virginia experience safe and affirming engagement and better health outcomes? It's a long question. And Reverend Patterson in particular, you told the Bub story. And immediately I thought of myself as a Black trans woman, and I thought of trans and non-binary folks who are so often called by names that we don't respond to.
Yeah. Good.
So we have a adolescent medicine specialist, Casey Kidd, whose specialty this is and whose research and care is all focused on adolescents and young adults who need, who are seeking transgender care. And I know that not just in Morgantown, but I'm not so sure about Casey, but the previous adolescent medicine person traveled to the southern part of the state routinely and held a clinic in Summersville, which is about an hour from here, to do that. I'm not aware, and I don't know if Dr. Kilkenny knows anything. I'm not aware that we have a specific problem with HIV entering our transgender community, although they are certainly at considerable risk. But I'm not aware that we have a problem yet. I don't know if Mike knows anything about that. Oh.
I do know that we go to all Pride events and do vaccination and testing or whatever services that we provide. And we have just a non-discrimination policy across the organization. And I do know that there have been times when we've made special accommodations for someone at our men's facility that needed a private room or whatever, and done it that way. So that's what I know about what we do with that.
And I'll just briefly add, in Huntington, we actually have one of the largest LGBTQIA populations in the state, because Huntington has made Huntington Pride an integral part and an open to all campaign. So we did open Marshall University, and partner with our homeless coalition, opened the center, which is just a place for adolescents to go who are unsheltered, and it draws generally the largest population of LGBTQIA. And then they have specific targeted interventions for youth to ensure that we're getting them into safe and appropriate care and out of violent situations, which is oftentimes their greatest risk. And then both our homeless coalition and most of our organizations are trained extensively sort of in greater interventions, being aware of situations that might come up. And I will commend Huntington. It did receive the first 100 in the state of West Virginia for the Municipality Equity Index for the United States. So we are very proud of making those adaptations to our recovery community.
Thank you. Ian will check on.
Thank you, everyone. The panelists, I really want to say thank you to each of you and all of you and your colleagues, because we're very grateful and we understand the challenges to do the work that you do in West Virginia. I really want to ask Lynn, I think you mentioned about the vision about the 10-year stigma reduction and the consistency on the message. What you will share that will be the biggest success and the biggest challenge from that approach. And also you mentioned in your remarks about receiving capacity building. What was the modality or the strategy that was more helpful? Thank you.
Thank you for that question. I'll answer the capacity building. So the state used state opioid response dollars to allow organizations to support a smaller organization when those were first released. Greater restriction has been placed on those fundings over time that really restricted it. There was also a legislative pass-through in West Virginia that allowed the medical schools to receive funding from from state opioid response dollars to provide areas, basically not to have to apply for a grant, to have a broader scope of work. And so ours, in partnership with WVU and the osteopathic school, were the recognition of the pipeline clogging, that you were getting physicians trained, but we were not getting mental health providers trained, and we were not getting peer coaches certified, and we weren't getting greater integration into the community. And so the three schools partnered on that for 3 years before that funding became highly restricted. And and really change that development and intervention, which I would argue needs to be altered. And I went to write your first question down and I did not.
On the stigma
Yes,
approach,
okay.
success and challenge.
Yes, I remember. As we're working on this at the sort of the state level, it's been getting multiple parties on board and having different approaches across sort of the idea of a campaign. For the first initiative was surveys and integration in on-the-ground communities. There were, we touched all 55 counties with 14 sessions of engagement and intervention and sort of a needs assessment, not just on stigma, but also on treatment and prevention and organization. After that, those references eventually became part of the ODCP strategic plan. And every year there are focus groups that occur. They just finished online that have everyone come online, and they're you're broken up into your different segment of interest, and you are able to give feedback on the plan and initiatives for the future. So everyone in the state has has an opportunity to engage. Now, broadband access does not equate equality. So at that point, we engaged all those interventions. We then took a group of sort of leaders who have been focused on stigma, those with lived experience, and solicited a research project that engaged people at all various levels about messaging that they found to be effective and messaging that they found to be non-effective. And those were tested. One of those has just been published this past week on sort of the idea of effective messaging and how to engage different age groups, which is one of the things that came out of that data. So really, we're trying to test and be flexible. One of the greatest things I think for Appalachia is things that work here will work other places. Things you bring here will not work here because we have the ability to be flexible. We have the ability to be on the ground, knowing what's happening. And I can be on the phone with Jim or Judith or anyone today when we leave here. I could be on the phone with Dr. Christensen. We just have a greater level of communication that allows us to be mobile and flexible and responsive that I've never experienced elsewhere.
I would like to make a last comment on Guillermo, if I can. Coming to West Virginia has really provided me with an extremely valuable and intense understanding of the problems in rural America. So it's not just West Virginia, and it's not just Appalachia, but I think in general, rural America is underserved by many federal agencies. And I would encourage PACHA to think about all of the agencies that are part of HHS and how they can focus some energy and resources into solving the problems in these parts of the country. We're important too.
Thank you. So we have two final questions, then we're going to wrap up because we're actually running close to time. So DeAndre Moore and Marvel Terry, if you guys could state your questions. You're passing, so I guess that's it then. Was there another question? Any final thoughts from the panel? So a round of applause for the panel. Thank you very much.
Gentlemen, thank you for putting such an awesome panel together. That was extremely informative. So we're now at the portion of our agenda for our lunch break from 12:35 to 1:15. If you are a PACHA member, our lunches are out the door and to the left, all the way down the hallway. Carolyn, would you like to?
Yes, for folks that are joining us for lunch, we are in the Emma Bird Gallery Room, which Tony Young has mentioned that Dr. Gupta has done a meeting in there. So we are excited to be in that room. It's kind of down the hall to the left, down another hall, up the staircase. So Katarina Kim is going to escort you to the room. So please go ahead and follow her and enjoy your lunch, and we'll see you soon.
And I will say for all PACHA members and our federal, when we come back and before we turn it over to Leo and Justin, I'm going to do a quick around the table, so to speak, because I did the roll call earlier, but we have so many new members. I want to say your name. I want you to tell us where you're from. That's for our federal PACHA, our federal colleagues and our PACHA members. So I'll take personal privilege of 5 to 7 minutes when we start back to do that so we can honor those in the space. And our virtual colleagues listening in and partners listening in can also benefit from that. So thank you. Enjoy your lunch.
Thank you.
Produced by the U.S. Department of Health and Human Services.